I'm Stefano, and I'm going to be going over the proper placement and insertion of a needle chest decompression.
The signs of suspected tension pneumothorax indicating the need for a needle decompression are when a casualty has significant torso trauma or primary blast injury and one or more of the following: severe or progressive respiratory distress, severe or progressive tachypnea, absent or markedly decreased breath sounds on one side of the chest, hemoglobin oxygen saturation less than 90% on pulse oximetry, shock or traumatic cardiac arrest without obviously fatal wounds. Use a 14 or 10 gauge 3 1/4 needle and catheter set and identify an insertion site.
Our site is the second intercostal space, mid-clavicular line, just lateral to the nipple. Palpating the clavicle, we know the first rib lies just under that. We have the first intercostal space, the second rib, second intercostal space, and the third rib. I'm going to use the third rib as the backboard, and then I'm going to ride over that third rib and advance the catheter and needle set into the pleural space. Once I pop through the pleural space, I'm going to advance the catheter until it is flush with the patient's skin.
After inserting the needle, hold it in place for 5 to 10 seconds to allow for decompression, and then remove the needle while leaving the catheter in place. If your first site is compromised, move to a second site.
Our site is located between the fourth and fifth intercostal space, anterior axillary line. Taking the anterior axillary line and moving lateral to the nipple, we will locate our site. Remember to go over the rib to avoid the nerve, artery, and vein bundle.
The needle decompression should be considered successful if respiratory distress improves, or there is an obvious hissing sound as air escapes from the chest when the NDC is performed. This may be difficult to appreciate in high-noise environments, or hemoglobin oxygen saturation increases to 90% or greater. Note that this may take several minutes and may not happen at altitude. Or a casualty with no vital signs has a return of consciousness and/or radial pulse.
If your casualty is conscious, place them in a position of comfort. Continue to reassess your patient for the redevelopment of a tension pneumo. Monitor their SpO2 and document all patient care on DD Form 1380.
If the initial NDC fails to improve the casualty's signs and symptoms from the suspected tension pneumothorax, then perform a second NDC on the same side of the chest, at whichever of the two recommended sites was not previously used. Use a new needle catheter unit for the second attempt. Consider, based on the mechanism of injury and physical findings, whether decompression of the opposite side of the chest may be needed. If the initial NDC was successful, but symptoms later reoccur, then perform another NDC at the same site that was previously used. Use a new needle catheter unit for the repeat NDC.